So we are back with another session. Opportunistic fungal infections are just that. They are opportunistic. And fungi are a part of our environment, always waiting for the opportunity to knock and for them to be able to get in. And they never miss it. So when there is an opportunity such as uncontrolled diabetes or immunosuppression, then, sorry, so, or also some things like medications that we use, like steroids, or disease that modify metabolism, like COVID itself. Or maybe on rare occasion, health services that are so overwhelmed and stretched that maybe they have forced in some ways to cut some corners. Now, all of these uh, are things that lead to a situation like we have now. Of course, mucormycosis was never particularly rare. It is the third most common fungal infection, and we have all almost seen it at different times. But it has received new dimensions with it was given the opportunity with thanks to COVID. And it was not just that the opportunity knocked, but basically it broke the door and came in. So greetings and welcome to the first of the CPC series where we go from diagnosis to treatment. It's brought to you by Oral Pathology 360 and through the Oral Pathology India channel. Welcome to this new session and the new season. So today we have with us Dr. Aditya Urs and Dr. Sujata Mohanty, both of who will discuss the case series, not just one case, but the whole case series that they have got from both the pre-COVID and the post-COVID times. The idea is not just to understand what is happening now, but to see if there are some differences. This will, of course, take time before we can publish such results, but experiences are also very valid and very important for us. And of course, I have to say this before we go on. This session is entirely for professionals, health professionals. So please do not consider this as being in any form a consultation otherwise. And yes, today, as usual, we normally have a moderator. We have experts, and our moderator today is Dr. Kalpaka Salvi, a good friend. She's a professor and head of department in the Vaidehi Institute of Dental Sciences, Bangalore. As she has put right on top of her CV, is that she loves teaching. So that really says she loves teaching. And slide discussions are her real area of interest. Otherwise, fibroosseous lesions, odontogenic tumors, and malignant lesions. She is a recognized PhD guide and also a fellow of the Indian Board of Forensic Odontology and the Indian Association of Oral and Maxillofacial Pathology. She will be moderating the session. We have an expert, Dr. Kotrishetty. Now, he is a good old friend. He has been actually my batchmate. So he is amongst the people who has known me the longest in dentistry. It's indeed a pleasure to have you here, Kotra. Then there is the department. He is the head professor at the Department of Oral and Maxillofacial Surgery, KLE Institute of Dental Sciences, Belgaum. He is a consultant in the KLE Smile Train, coordinator at KLE Oral Implantology Department and the Center for the Correction of Dentofacial Deformities at KLE. He has 28 years of experience, more than 50 publications, 100 presentations, and this is just his short CV. We also have a special guest with us who is also not new to the channel, Dr. Raghu Radhakrishnan from MCOTS Manipal, who's also had a whole series of these cases and just decided to join us for that additional bit of discussion. So essentially, every one of these people today with us have had a lot of experience, both pre-COVID and post-COVID, and I'm sure there are those in the audience who will also have a lot to add in. With this, I will request Dr. Selvi to please take over and introduce the speakers, and then we go on from there. Thank you.
Good morning, and thank you, Dr. Mandana, for your kind words. It's my honor to introduce today's speaker. The first speaker, Dr. Aditya B. Urs, is senior professor and head of the department at Maulana Azad Institute of Dental Sciences, New Delhi. She's a keen academician with over 20 years of experience teaching both undergraduates and postgraduates. She has expertise in reporting histopathology, cytology, fine needle aspiration cytology of head and neck pathology, with special emphasis on odontogenic cysts, tumors, sarcomas, and maxillary sinus pathology. She has more than 80 scientific publications to her credit, and she has been invited as a speaker to many events. She has also supervised 2 research projects relating to Candida in oral lichen planus and role of SH gene for and PTEN in amyloblastoma. Welcome, Dr. Aditya. The second
Good
speaker,
morning.
the second speaker of the day is Dr. Sujata Mohanty, Professor and Head Department of Oral Maxillofacial Surgery at Maulana Azad Institute of Dental Sciences, New Delhi. She has vast experience of 23 years with significant contribution in field of research through 82 publications and 2 book chapters in well-known oral and maxillofacial surgical textbooks. Her area of interest is TMJ surgery, orthognathic surgery, maxillofacial pathology, oral cancer, and facial trauma. Welcome, Dr. Sujata. And we'll start today's session with Dr. Aditya Burs.
So while Dr. Aditya gets her presentation on going, I just like to remind everybody, in case you have not already subscribed and you find the channel interesting, please take the moment to hit subscribe to help us with this whole movement and to support it. Thank you.
Is my screen visible?
Your screen, yes, it is visible.
Is it fully visible or is it not on slideshow?
It's not on slideshow as yet.
1 second. I put it on slideshow. 1 second, please.
No problem.
Slideshow. Please. Okay, now is it visible?
Yes, yes, it is. Your slideshow is on. Yeah, please start.
So do I start?
Yes, please. Yes.
Okay. Good morning to one and all. At the outset, I would first like to thank Dr. Mandana for inviting me to present this update on mucormycosis in the pre-COVID and COVID era. And also thank Dr. Selvi for a wonderful introduction. And before I go ahead with my presentation, I would like to mention here that I would be presenting on the pathogenesis, the clinical features, and the laboratory diagnostic aspects of mucormycosis. And Dr. Sujata Mohanty will be covering the radiological and the treatment aspects of mucormycosis, both covering the pre-COVID and the COVID era. So now, what is mucormycosis, or how does it affect the general population? Now, mucormycosis is a life-threatening opportunistic infection, and India has the highest burden of mucormycosis in the world, where the estimated prevalence of 140 cases per million population. And in the recent literature update, we have that 71% cases in the world which has been reported are all reported from India. And mucor has a very high prolific spore forming capacity, because of which it is the third most common invasive mycosis after candidiasis and aspergillosis. And the most important characteristic feature about mucor is that it is angio-invasive in nature. So now, where does mucor come from? It's actually present all throughout the environment, and it's mainly saprophytic in nature, and it's present in the soil. But it can also be present all throughout in the environment on leaf litter, or it can also be growing in any composing matter where there is a carbohydrate substrate which is present. And it can also be sometimes present in bread molds. So, and it best grows in a humidified environment. So it enters the human body through the sinuses and then affects the lungs after the inhalation of the fungal spores. It can also enter through the skin after a cut, burn, or any other type of skin injury. And in the oral cavity, sometimes you can see that it can enter through the disease periodontium. And of course, the most important factor for mucormycosis to actually take place is that it usually occurs in people who have a weakened immune system. So now moving on to the taxonomy of mucor, it belongs to the subphylum Mucormycotina, order Mucorales, and there are 4 species within it, that is Lichthemia, Mucor, Rhizomucor, and Rhizopus. So it among these, the Rhizopus species is the most common infection, followed by Mucor, And again, as I said, it is most commonly seen in the immunocompromised patients, like where there's an underlying diabetes mellitus, neutropenia, or organ transplantation. Now, how does mucormycosis actually start infiltrating into the host system? So normally, when any person inhales the spores of mucor, the body's innate defense mechanism will try to come into action and try to remove the mucor from the body. So it is ingested by the alveolar macrophages and also the neutrophils, and they will remove it from the body. But in cases where this does not happen, because there is a qualitative as well as a quantitative dysfunction of the neutrophils, because of which the spores will germinate into the mycelial form. And once it germinates into the mycelial form, it will start entering through the blood vessels. So it is angioinvasive in nature, and then ultimately it will lead to infarction and necrosis. Now, I would like to highlight if there's any difference in the pathogenesis of mucormycosis in non-COVID and COVID patients. So first, I would like to talk about the risk factors in the non-COVID cases. So as we all know, it is occurring in any immunocompromised condition, of which the predominant one would be diabetes mellitus. But apart from that, it can also be seen in organ transplantation, renal failure, long-term corticosteroids, and in AIDS. Now, an important point to remember that in AIDS, it's usually a dysfunction of the CD4, CD8 lymphocyte ratio, and there's no dysfunction of neutrophils which is taking place. So unless it is associated with drug abuse, usually mucormycosis is not seen in AIDS patients. So what happens in diabetes mellitus? We have a scenario where there is ketoacidosis, and when there is ketoacidosis, there is a low serum pH, which diminishes the phagocytic effect of macrophages. And along with that, there is a release of iron, which is bound to the proteins. And in this environment, where the iron is rich in that environment, it favors the growth of mucor. So Rhizopus species has an active ketone reductase system. As I already told you, Rhizopus species is the most common one which is affecting the body. So this has an active ketone reductase system, and it thrives in high glucose and acidic conditions. Apart from this, the decreased phagocytic activity can be due to impaired glutathione pathway. Then the second cause would be the long-term intake of corticosteroids. So this reduces the phagocytic activity of WBCs. Along with that, there is impairment of macrophages migration, ingestion, and phagolysosome fusion. And it also induces neoglucogenesis. So there's more and more amount of glucose which is being produced, because of which it again favors the growth of mucormycosis. Now, coming on to the risk factors which are associated with the COVID cases. So as I already mentioned, again here, the uncontrolled diabetes would be the primary risk factor. But apart from that, there has been an increase in the usage of corticosteroids in the second wave of COVID, due to which we are seeing that there are high number of cases of mucormycosis being reported. And apart from that, the other causes which have been supposed are like the oxygen therapy or a prolonged stay in the ICU, or even overdose of steam inhalation. Now, oxygen therapy, especially it is with respect to the humidifier which is being used, and if it is not sterile, it can also lead to the condition that it is causing mucormycosis. Now, when I was reading up literature regarding the pathogenesis of COVID-19, I found a very interesting hypothesis about neutrophil interaction and hyperinflammation in COVID-19. So here, what happens is that when the SARS-CoV-2 virus enters the human body, it is recognized by the host. And once it is recognized by the host will respond by increasing the number of neutrophils. So there is an neutrophilic infiltration. So neutrophilic infiltration takes place. Along with that, the cytokines interleukin 1, 6, and 8, tumor necrosis factor alpha, all of them are increased along with reactive oxygen species, and it causes a cytokine storm. We are all aware of the cytokine storm, which is one of the predominant feature which we see in COVID-19. So this is causing a condition of hyperinflammation. So when this hyperinflammation happens, there is something called NET production. Now, what is NET? NETs are neutrophil extracellular traps. These are extracellular webs of chromatin and microbiocidal proteins, which are part of the innate immune host defense. And they contain DNA, modified extracellular histones, proteases, and cytotoxic enzymes, which allow the neutrophils to centralize the lethal proteins at injection sites. So this production of NEPs leads to a cascade of inflammatory reactions, which favors microthrombosis. So it has been found in a study cohort that patients hospitalized with COVID-19 had significantly elevated levels of NEP as compared to healthy controls. And also they have found that the neutrophil lymphocyte ratio, that is the NLR ratio, is highly increased in patients with COVID-19. So since this NET production is favoring thrombosis, so and mucormycosis also has thrombosis, there could be a possible link in the pathogenesis that as to why we are seeing such a high instance of mucormycosis in COVID patients. And this is some area of research which would probably be carried forward to see if there is any link between these two. Apart from this, there is also something which is known as GRP78, that is glucose regulated protein. Now this is increased in expression in COVID-19 patients. So what usually happens is endothelial adhesion and penetration are critical early steps in mucormycosis. So acidemic states and hyperglycemia induce the increased expression of this GRP78, and this helps in increased adhesion and penetration of mucorales into the endothelium. So this is overall going to help in the further invasion of mucormycosis to happen at a fast rate. Apart from that, you can also see endotheliitis and endothelial damage associated with thrombosis and leukopenia in COVID-19. And there are certain other factors which you see, like you can see reduction in the CD4 and CD8 levels, but I would say that this predisposes to other infections and not to mucormycosis. Now, moving on to the clinical types of mucormycosis, we have rhinocerebral, pulmonary, cutaneous, gastrointestinal, disseminated, and isolated renal mucormycosis. But as head and neck specialists, most of the time we come across only the rhinocerebral mucormycosis, though of course, to a certain extent, we can also see the pulmonary mucormycosis. So now moving on to the clinical features with which the patient usually presents, he usually complains of fever, rhinorrhea, headache, facial pain, ocular pain, or lethargy. And the oral symptoms would be that the patient probably complain of mobile teeth, sinus tract formation, necrotic bone associated with brownish blood-stained nasal discharge. And then when it moves on to the orbital involvement, there might be chemosis, periorbital cellulitis, ophthalmoplegia, and proptosis. And in the cerebral component, then the patient can complain of severe headache, bilateral proptosis, paralysis, altered consciousness, and seizures. So moving on to the stages of rhinocerebral mucormycosis. In stage 1, we have only rhinomaxillary, where it is in the early stages, we usually have rhinomaxillary. Now, the latest guidelines have divided this stage into 2 parts. That is, in the very first stage, it's involving only the nasal cavity, and later on, it involves the paranasal sinuses. So here you can see an image where you can see necrotic bone in the right maxillary quadrant. Then in the stage 2, it spreads to the orbit. Over here, you can see a patient with periorbital cellulitis as well as proptosis. And usually it is a pterygopalatine fossa which acts as a reservoir for mucor to reside over there, through which it spreads through the orbit. And then in the third stage, it goes to the cerebrum, where the spread is through the cribriform plate. Now, these are the routine investigations which we would be advising to all patients with suspicion of mucormycosis. As I already said, the imaging findings will be discussed by Dr. Sujata Mohanty. I would move on now to the laboratory investigations of mucormycosis. Now, what are the diagnostic modalities which are available with us? So first we have the KOH mount, followed by the calcofluor white stain. Then we can have culture. And then, of course, we have histopathology associated with special stains. So first, I would like to highlight a few points about the KOH mount. Now, this is a very rapid and inexpensive method by which we can identify mucor. And what we have to normally do is that we have to just take a specimen, which may be either from a nasal swab or a bronchoalveolar lavage, and put it onto the swab can be put onto a slide and mixed with 10% KOH solution and covered with a cover slip, and then immediately observed the microscope. So when it is observed on the microscope, you can see that it will be showing this thick non-septate hyphae, which are ribbon shaped and branching at 90 degrees. Now, this might not give you very clear visualization. So supposing we use a calcofluor stain, which is a fluorescent stain, and it will lead to better visualization of the mucor hyphae. And of course, we would be needing a fluorescent microscope to see the mucor hyphae. Now moving on to culture. Now this is a very important step to identify the species. But the main disadvantage is that if we do not handle the specimen properly, then false negative results are a very high component in specimens submitted for mucor evaluation. So whenever the specimen is taken, we should not mishandle the specimen that we have received, and it should be immediately inoculated into the culture without any manipulation. So usually the material is inoculated into Sabro's dextrose agar, and the colonies are usually grown within 3 to 7 days. And they're usually gray to white colored colonies, which may even have a fluffy cotton candy kind of appearance. And the growth would be so elaborate, so much that it will come on to the lid of the culture medium, and that is why they're known as lid lifters. Apart from that, on further growth, and when we try to identify the species, then we will be able to see that you are able to see a sporangium, which is having the sporangiospores within it. Now moving on to the histopathology and the special stains. Now, whenever we are suspecting a fungal infection, there are certain features in histopathology that we should always try to identify so that we can arrive at a confirmatory diagnosis. So the first among this is that we always, most of the time we see that there is a granulomatous reaction in any kind of fungal infection. So you can see granuloma formation, and most of the time, and then you keep searching for in the tissue and you might not find the fungal hyphae. So usually then we need to do a special stain like PAS. And over here you can see that where the arrows are showing, you're able to see the fungal hyphae which is residing within the giant cells. Apart from this, you will normally see an acute infiltration of acute inflammatory cells, predominantly neutrophils. Maybe along with that, lymphocytic infiltration is also present. And then further, when we search, we might see the fungal hyphae or the spores. Now, as I already mentioned, the fungal hyphae of mucor are broad, aseptate. They can be pauciseptate also, but they will show typical branching at 90 degrees. And then on GMS, which is a special stain which can specifically identify mucor, it can be better visualized, and if any doubt, it will definitely clarify that it is mucormycosis. Apart from that, we should also look for vessel invasion, and over here you can see that there are 2 or 3 mucor hyphae which have invaded into the lumen of the blood vessel. Now, apart from this, also, we should always keep in mind that certain artifacts can occur because patients most of the time present with an oroentral fistula. So the patient can have some vegetative matter within the sinus, and sometimes on GMS, even this can come positive, as I've shown over here, that this is actually vegetative matter which has stained positive. So we have to look carefully for the morphology of the mucor to identify whether it is actually an artifact or whether it is the mucor hyphae. So now I have a diagnostic algorithm for the examination of coming to a confirmatory diagnosis of mucormycosis. So if we see broad non-septate ribbon-like hyphae at 90 degrees angulation branching, and along with that the culture is negative, we come to a diagnosis of mucormycosis. And if you're having both on histopathology as well as culture positive, then definitely it leads to a diagnosis of mucormycosis. But supposing on histopathology we see no hyphae, but we get positive results on culture, then we should still suspect that mucormycosis is still there, and we should repeat the test. And on the other hand, if all are negative, then the patient is negative for mucormycosis. So now I would move on to the case discussion, wherein I'll be presenting 2 cases which are of non-COVID and 2 cases which would be of the with a COVID history. So the first case here is a 34-year-old male patient who presented with a swelling on the left side of the face involving the eye for the last 1 month. And he had a history of uncontrolled diabetes mellitus. So you can see over here, the patient is having periorbital cellulitis associated with proptosis, and intraorally, there was only a mild swelling with superficial ulceration of the mucosa. The imaging findings showed opacification of the left maxillary sinus along with the left nasal cavity, and the tissue was excised from the intraoral site, and the tissue submitted to us was whitish in color, soft in consistency. And on histopathology, we can see that we have an epithelial lining which is of pseudostratified columnar in nature, and below the epithelium you can see that there is a mild to moderate inflammatory cell infiltrate. In other areas, you can see that there is a dense inflammatory cell infiltrate which is present, associated with some areas of hemorrhage. This is a higher par view showing you the neutrophilic infiltrate and the lymphocytic infiltrate. And And other areas, again, now we can find that there are typical, the mucor hyphae which are present, which are broad aseptate and they're branching at 90 degrees. Further views of the same section, we can see in cross section here. And this is the GMS stain where you can easily identify and it confirms the diagnosis of mucormycosis. Now moving on to the second case, this is a very interesting case. This is a 76-year-old female patient who presented with a complaint of a non-healing extraction wound since 6 to 7 months. And she had a history of extraction of 1617 8 months back. So there was associated pain, discomfort, and mobility of the bone along with halitosis. And she had a history of diabetes mellitus since 10 years with irregular episodes of treatment. So clinically here you can see that she presented with oroentral fistula with the presence of necrotic bone in the inner aspect of this oroentral fistula. The imaging findings are showing opacification of the right maxillary sinus along with a destruction of bone in the right posterior maxillary quadrant. This is a gross specimen that we received. It was just a dry necrotic bone which we have received. So the specimen was decalcified and sections were taken. So what does the histopathology show? Now here we can see that the bone is non-vital and we can see a mixture of some broad hyphae as well as a few thin hyphae which can be seen in this low par view. Then when we move to the further sections, here you can see the thick arrow is showing you an area where you're seeing the cross sections of the fungal hyphae which are a little bit larger in size, and the thinner arrows are showing you the thin hyphae which are there, and the thin hyphae are multiple in number all throughout the section. Now a higher par view of the central part of the section here you can see that these are showing cross section of the mucor hyphae, and along with that there are some tiny spores which are half the size of this which are also present. Now again another view of the same thing here where the yellow arrow is showing you the mucor hyphae and the arrow which is the red arrow is representing the septate fungal hyphae with branching also present over here. So like that there are many others which are present over here. All of them are showing septate fungal hyphae. So on higher magnification, again, we have mucor hyphae with some cross sections. And in GMS, we can identify here that the left-sided image is showing you the mucor hyphae, though mucor is said to be non-septate, but sometimes you can have pauciseptations also. So here we are able to appreciate that there is pauciseptate. And along with that, in the other image which we have over here, these are septate fungal hyphae which are thinner with branching at 45 degrees. And this would be probably suggestive of Asper. So now when I move to the next section here, this is again a cross section where you can see multiple spores, multiple cross section of mucor hyphae. Along with that, there are tiny spores which are present, which are represented by the red arrow, and these are all very small in size. Then further sections showed us again the non-vital bone associated with fruiting bodies of aspergillosis, and these are nothing but in GMS stain, it showed us that it can be identified as Aspergillus niger, and you can see very well that it is present within the section. Along with associated with that, there are other mucor hyphae also just superficial to it or just above it. Then in other areas, again, we saw that there was a typical appearance of actinomycosis where you can see the sundry appearance which is there present on the surface of the bone. The GMS stain again showing you the same actinomycotic features. So this case was diagnosed as chronic osteomyelitis associated with a combination of mucormycosis, aspergillosis, and actinomycosis. Now moving on to the third case. This is a 51-year-old male patient who complained of pus discharge from the upper front tooth region since 2 months, and there's history of COVID-19, diabetes mellitus under medication, and history of steroids during treatment of COVID-19. So here you can see that there is a pus discharge from the second quadrant. Here again you can see the image. And here the CT findings or the imaging findings showed only mild mucosal thickening of the left maxillary sinus with extension into the left ethmoidal air sinuses. Now this patient underwent excisional biopsy wherein we received a combination of both hard tissue as well as soft tissue. You can see here that there's extensive areas of hemorrhage in the gross appearance of the tissue. Along with that, there were some bits of hard tissue which was submitted. Now, when we observe the histopathology of this particular case, you can see that the maxillary sinus lining is evident, again, lined by pseudostratified ciliated columnar epithelium. But you can see that just below the epithelium, there is a dense infiltration of inflammatory cells associated with large areas of necrosis and hemorrhage. Now these are the, on higher power view, this is showing you areas of necrosis. And also associated with that, we could see plenty of granuloma formation. Now, on other sections showed us there was an abundant infiltration of fungal hyphae, predominantly of mucor. And you can see in this section the number of hyphae which have infiltrated into the section. It is just phenomenal. When you see the section, I had never seen a section which was filled with so much of mucor hyphae earlier. And this is a higher power view of the same. On H&E, it is visible. Again, higher power view. And you can see the branching at 90 degrees, broad aseptate fungal hyphae ribbon shape, very characteristically. This is the GMS stain. And again here, the GMS stain confirms the diagnosis of mucormycosis because they're all broad shaped with branching at 90 degrees. Now, moving on to the last case. This is a 45-year-old male patient who complained of a draining sinus in the upper front tooth region since 1 month, associated with pain and purulent pus discharge. Here you can see that he had multiple draining sinuses over here. And along with that, again, patient had a history of diabetes mellitus. And patient was negative on RT-PCR, but he had a HRCT score of 14 on 25, suggestive of COVID pneumonia. It also was associated with a palatal swelling. Now, the imaging findings have shown that there is moderate polypoidal thickening in the sinus associated with mild erosion of the walls of the maxillary sinus. Now, this patient underwent hemimaxillectomy, and this is the gross specimen that we have received. So again, here you can see it's a combination of both hard tissue and soft tissue, and there are areas of hemorrhage which are associated with it, where it's all brownish in color. Now here, the tissue shows us on histopathological examination, it shows the maxillary sinus lining again, and below which you can see that there is a dense infiltration of inflammatory cells associated with abundant hemorrhage. So here on higher power view, you can see that there's abundant hemorrhage associated with necrosis. And again, we are seeing that there are so many granuloma formations which are taking place over here. And the other soft tissue areas have shown that there was infiltration by the mucor hyphae, very characteristic appearance, higher power view of the same field. And along with that, here in this particular slide, we found few thin hyphae also present, but we were not able to characterize it specifically as to which type of hyphae because they were not characteristic of Asper hyphae. Now, this is a GMS stain slide, and here you'll be able to appreciate the amount of hyphae which is present in the section. And this is again the higher power view of the same. So, a final diagnosis of mucormycosis was given for this patient also. Now, we wanted to just highlight if there was any difference in the histopathology of mucormycosis when there's a history of COVID-19 and when there is no history of COVID-19. So what did we observe on comparison of the gross specimen as well as on the histopathological examination? So we found that earlier in the pre-COVID era, whenever we used to get cases of mucormycosis, we used to only get dry necrotic bone. Whereas over here now in the COVID cases, we found that the necrotic bone was associated with hemorrhagic areas. And on histopathological examination, we found more fungal hyphae per high power field. I've shown you the sections where it was literally filled with fungal hyphae, whereas we used to just get only 3 or 4 or 5 fungal hyphae per high power field in the pre-COVID era. And there is abundant necrosis and hemorrhage in the sections now in the mucormycosis associated with COVID, whereas there was less necrosis and hemorrhage earlier. And we are also observing numerous granulomatous aggregates in the COVID cases, whereas it was rarely observed in the pre-COVID era. So now I would like to conclude by saying that diagnosis relies on a concentration of high index of suspicion, assessment of the presenting signs and symptoms, imaging studies, culture, and direct examination of the clinical specimens and histopathology. Since the tendency for the culture to be positive only in around 15 to 25% of the cases, so histopathology is the gold standard for diagnosis of mucormycosis, and there should be rapid and prompt initiation of treatment early in the course of the disease, because of which then it will reduce the morbidity and the mortality by almost half. So I would now hand over to Dr. Sujata Mohanty to take over. And before that, I would like to thank my department staff and my faculty and my postgraduate students who are the motivational force behind me. I would also thank the postgraduate students for the exceptional staining which they have done for all the cases. And I would like to thank my PG, Dr. Kiran Jyot, who has helped me with this presentation. Dr. Selvi, would you like to take over?
Yes, Dr. Suchata, you can start.
Just a moment.
Yeah, no worries. Take your time.
Very good afternoon to all of you, and thank you, Dr. Mandana, for inviting me to speak on mucormycosis in the pre-COVID and COVID era. And I would also like to thank your team, and very good afternoon to the participants. I'll straight away start with Rhino Cerebral Mucormycosis, which we usually get to see. We don't get to see other kinds of mucormycosis. And first, I would make my observations, what we have seen during the pre-COVID era and the COVID era. I have seen very less number of mucormycosis in my 23 and more years of career. I've seen only maybe 25 cases of mucormycosis. And during this second wave of COVID pandemic, we have come across a number of mucormycosis cases, and mostly we are seeing around 3 to 5 mucormycosis case every day since the past 1 month. The clinical picture is similar, except we have seen a long course, a chronic course in the pre-COVID era. Whereas during this COVID era, the mucormycosis has a faster onset along with faster progress, with multiple gingival abscesses and sinuses, which were not very much prevalent during the pre-COVID era. There is rapid involvement of the orbital and cranial structures. It becomes very fulminating and is high. It has a high mortality rate. The parameters in both the pre-COVID as well as COVID era, we are seeing patients with uncontrolled diabetes, which are reporting with mucormycosis. But in pre-COVID era, rarely patients were immunocompromised, and mostly it used to affect the older age group, and most of them were smokers as well. But during the COVID era, mostly the patients are immunocompromised. There is a history of hospital admission with confirmed COVID infection, or even if there is no confirmed COVID infection, still if the patient is having fever, sore throat, or self-medication within a short span of time, then also the patients are ending up with mucormycosis. They were usually on steroids and self-medicated patients, and we are also seeing a lot of younger age group patients being affected with mucormycosis. We are advising similar investigations, except that during this COVID phase, we are also advising the patient inflammatory markers, COVID-19 serum antibodies in patients who do not have a history of COVID-19 infection, but have history of some sort of symptoms of the COVID-19 infection, and also HRCT. Intraoperatively, we usually find dry and sclerotic bone in case of a pre-COVID mucormycosis. And during COVID era, there is a presence of lot of pus, and the specimen is porous, and there is lot of hemorrhage in the porous bone. This is dirty in appearance. And there is, we are also seeing a sudden spike in blood pressure and heart rate in all the patients when we are operating under local anesthesia. And there is no history of blood pressure or tachycardia in such patients previous to the COVID infection. Coming to the risk factors, the major risk factors I would say are recent infections with the new COVID-19 mutant strain, because during the first COVID infection, first wave, we saw only 2 or 3 mucormycosis cases, but now during this second wave, we are getting to see many of them. Uncontrolled diabetes mellitus and ketoacidosis, and the pathophysiology has already been discussed about Dr. Aditya. Immunocompromised patients, excessive use of zinc supplements, because it has been reported that heavy metals like zinc supplements, iron, selenium, and manganese, they facilitate the growth of the fungi. Injudicious use of immunomodulatory agents like corticosteroids and antineoplastic drugs. Concurrent use of antibiotics, because if we use antibiotics unnecessarily, even though there is absence of bacterial infections, that will result in a disturbance of resident oronasal microflora and result in opportunistic infection. They can also happen in major burns where there is abundance of organic matter, severe trauma patients like in cases of tornadoes, tsunamis, and war, because of the environment and degree of trauma, and the fungal spores getting impregnated into the traumatic site. In case of protein energy malnutrition, increased inflammatory markers. Now we are seeing a increase in the levels of serum ferritin, mostly in patients who are getting this mucormycosis during this COVID era. Other risk factors include neutropenia, malignancies, intravenous drug abuse, prematurity, and low birth weight, mostly in gastrointestinal mucormycosis, which we don't get to see, HIV/AIDS infection, chronic kidney disease, liver cirrhosis and hepatic failure, and old age. And during this COVID era, we have come across 15 to 20% of patients who have no evidence of any underlying conditions, but still they are suffering from mucormycosis. Coming to the diagnosis, clinically, the patient may present to us with mild symptoms and signs like pain in a single tooth or mobility of a single tooth, paresthesia of the cheek or the mandible. There may be mobility of a part of the bone or presence of multiple gingival abscesses, mobility of multiple teeth, presence of necrotic and exposed bone, exposed roots of the teeth, swelling of one side of the face with deviated nasal septum, ophthalmic involvement presenting as ophthalmoplegia, proptosis, chemosis, and there might be some disfigurement of the face. Lab investigations, as already is discussed by Dr. Aditya, I would like to stress upon the fact that the complete blood count, fasting blood sugar, PP, HbA1c, liver function test, kidney function test, and serum electrolyte should also be used regularly. They should be advised regularly if the patient is on antifungal drugs, because most of them are nephrotoxic and some of them are also hepatotoxic. Diagnostic nasal endoscopy, imaging, then histopathology, as already stated, that it is the gold standard to diagnose fungal mucormycosis. Fungal culture, it is not available with us, so we do not advise fungal culture. We also go for bacterial culture and sensitivity along with histopathology when we remove the specimen in order to rule out any bacterial infection. If the bacterial culture and sensitivity comes out to be positive and is sensitive to certain drugs, then we definitely start with antibacterials depending on the sensitivity results. Now, radiographic parameters of mucormycosis, which help in the diagnosis as well as planning the treatment. The gold standard in imaging are gadolinium enhanced MRI and CT-PNS with contrast. The features which we come to see on MRI are perisinusal spread as hypointense signal in T2 weighted images, osseous erosion as T2 weighted hypointense signal, mucosal thickening as hypointense signal on T1 and hyperintense on T2. The features on contrast enhanced CT-PNS of involvement of mucous membrane and the sinuses and the bone show mucosal thickening, inflammation of nasal turbinate, bony erosion, sinus opacity, and sequestered bone. I will show you some of the sections of CT and MRI to get a feel of it. Here you can you can see the coronal section of the CT scan. Here you can, of the paranasal sinuses, you can see the sinus lining. There is thickening of the maxillary sinus lining, and the maxillary sinus lining on the axial section is obliterated. On MRI, you can see there is obliteration of the sinus on the then maxillary and ethmoid sinus involvement. Here you can see on the coronal section, both the maxillary as well as the ethmoid sinus involved on the right side, and partially the ethmoid sinus is involved here. Here you can very well see the involvement of the maxillary and ethmoid sinus, and here the ethmoid sinus is involved. This section shows the involvement of frontal sinuses, so involving the cranial cavity. So this is Rhino Cerebral Mucormycosis. Here you can see all the sinus being involved, like the maxillary, the ethmoid, the frontal, and here you can see some thickening in the sphenoidal, thickening of mucosal membranes in the sphenoidal sinus. There is a breach of bone here and some erosion. Here it is the ethmoid sinuses are breaching the orbital wall. So those are some presentations on radiographs and CT scans and MRIs. Now coming to the prevention and treatment of mucormycosis. Now prevention, environmental cleanliness is of utmost importance, and one should not have any exposure to decaying organic matters like food materials, soil, compost, excreta, etc. And mostly during this COVID period, especially when a patient is suffering from COVID infection, known COVID infection, or some signs and symptoms of COVID. One should use a double mask covering nose and mouth. Maintenance of personal hygiene is of utmost importance. One should always brush one's teeth, clean the tongue, and use mouthwash containing povidone iodine or methylene blue. Hyperglycemic control with strict blood sugar monitoring. Optimal use of steroid at the right time, right dose, and right duration, and these has to be done under supervision of a physician, and self-medication has to be avoided at any cost. Clean distilled water to be used for humidifiers if the patient is on oxygen therapy and is admitted. Use of antibiotics and antifungals should be indicated, should be used only when indicated. Management of mucormycosis during this COVID era is completely a multidisciplinary team approach, including a team of physicians, endocrinologists, ENT surgeons, oral and maxillofacial surgeon, ophthalmologist, neurosurgeon, plastic surgeon, anesthetist, radiologist, and a dietitian. Is the first line of treatment for mucormycosis, which should be, and the first line should be aggressive debridement till creation of good vascular bed. If on radiographs or CT scan and MRI, we see only nasal and sinus involvement without any bony erosion, only functional endoscopic sinus surgery will do, but this is very rare. Mostly when patient report to us, there is definitely some bony erosion in the form of involvement of the alveolus, maxilla, or mandible, or zygoma. In such cases, extraction of involved teeth have to be done along with alveolectomy and resection of the involved part of the maxilla, mandible, or zygoma. If there is orbital involvement, one has to go for orbital exenteration, and if cerebral involvement is there, then neurosurgical intervention is required. Adjuncts to surgical debridement are antifungal and or antibacterial drugs, depending on the culture and sensitivity report. Hyperbaric oxygen therapy can be considered in select group of patients. Local application of methylene blue, acetic acid, gentian violet, amphotericin B gel can be used. Local infiltration and local lavage with amphotericin B injection. Methylene blue nebulization, use of obturators till definitive reconstruction, and secondary reconstruction should be considered along with rehabilitation once the patient is free of disease, which we can know from phase, subsequent phase, as well as from the radiographs and the radiographs. Coming to hyperbaric oxygen therapy, the successful use of this adjunct has been reported since 1980s. And we use Mark's Miami protocol of 30 dives greater than 1.5 atm pressure for 90 minutes in patients, mostly in patients who are toxic to antifungal drugs, and also who have some residual disease in those, and who do not have these conditions like chronic obstructive pulmonary disease, claustrophobia, acute acute upper respiratory infection, optic neuritis, eustachian tube dysfunction, and immunocompromised states. And they can also be used for residual disease and also to decrease the progress of the disease, because the pathophysiology behind using hyperbaric oxygen therapy is that they counter the anaerobism. They also improve the hypovascularity, hypocellularity, and hypoxia of the mucormycosis, the necrotic bone, or the bone surrounding the necrosis. And these are articles which favor the use of hyperbaric oxygen therapy in Rhino cerebral mucormycosis. And they have shown that there is improvement in the condition of the patient, and also it has decreased the mortality rate. But in COVID-related mucormycosis, their use should be restricted, and in patients only where the HRCT scores are low and there is no evidence of lungs infection. The effectivity of the dyes like methylene blue, acetic acid, and gentian violet are proven as antibacterial and local antifungal agents. So they can be applied locally after surgical debridement. In medical management, the most important factor to consider is the control of diabetes, or to check the sugar levels under control, to reduce and discontinue steroids, and to discontinue immunomodulators, and they have to be done under supervision of a physician or endocrinologist. Self-medication to be avoided, antifungal treatment after debridement, antibiotics if only superimposed with bacterial infection, or if on biopsy one finds if on culture one finds bacterial osteomyelitis, then one has to start antibiotics rather than antifungal. It depends on the culture and sensitivity. And also it includes diet modification. One has to reduce sugar intake. Antifungal treatment, the first line of antifungals include injectable pollines like liposomal and deoxycholate amphotericin B. Second line of antifungals are posaconazole, isavuconazole. Third lines are voriconazole, both in injectable as well as peroral forms. Combination of antifungals is not recommended because there is no data supporting the synergistic effect of antifungals. Isavuconazole and posaconazole infusions and delayed release tablets can be kept for salvage treatment, mostly in patients who are non-responsive to amphotericin B or who develop toxicity to these drugs. Duration of antifungal therapy for mucormycosis is unknown, and it can be continued till clinical and radiographic resolution of infection is seen, which may take weeks to months, and it also depends on the immune defect to be resolved. Now, these are the drugs which are used as first-line drugs, the liposomal and the deoxycholate amphotericin B. at a doses of 5 to 10 milligrams per kg per day for 3 to 6 weeks, and it has to be infused with 200 ml of 5% dextrose over 2 to 3 hours in a indoor facility. Amphotericin B should not be administered in the outdoor facility because unwanted drug reaction or infusion reactions are very common, mostly with the deoxycholate group. Side effects are nephrotoxicity, hypokalemia, hypertension, and erythema. So monitoring of renal function, potassium and magnesium level by getting serum electrolyte tests every 5 days done should be, they should be monitored. And amphotericin B, these are very cheap. They are cheaper options of liposomal amphotericin B, but are more toxic. The doses is 1 to 1.5 milligram per kg per day for 3 to 6 weeks. And they also have to be administered with 5% dextrose, but over a period, more longer period and in a hospital setup. Here also renal function test, serum electrolytes have to be repeated every 5 days. Liposomal amphotericin B is safer with and is associated with less infusion related reactions. But the availability of amphotericin B injection is an issue. So when there is availability issue, we can use isavuconazole. This is also not available. So we are mostly using posaconazole tablets, which is a broad spectrum second generation azole. It can rarely cause clinically apparent acute drug induced liver injury. So it is hepatotoxic. So liver function tests have to be repeated every week. The doses is 30 milligrams twice daily on the first day of surgery, first day when we start this drug, and then 300 milligrams per day for 3 to 6 weeks. Another thing I want to add is if the patient is on amphotericin B and is going to shift to oral azole, then posaconazole should be started 1 week to 10 days prior to stopping amphotericin B, because posaconazole crosses the blood-brain barrier very slowly, and it reaches its peak plasma half-life after days. Usually the global guideline for diagnosis and management of mucormycosis by the European Confederation of Medical Mycology in cooperation with the Mycosis Study Group Education and Research Consortium is followed in the treatment of mucormycosis. Now I'll come to our experience in our department, what we have seen in the pre-COVID and COVID era. This was a female who reported to us, 60-year-old female with a history of trauma and necrotic bone on her left side of face. And you can see on the CT scan, there is presence of necrotic bone and it is separated from the surrounding bone. So it was excised and waited till we came across bleeding healthy bone, and it was reconstructed with buccal fat pad to support the skin and subcutaneous tissues. Another patient, 64-year-old male, reported to us with multiple sinuses, with a history of multiple gingival sinuses, with history of spontaneous exfoliation of teeth. And he was a patient of chronic kidney disease. So we didn't start antifungal treatment. We sent the bone, the necrosed bone was not mobile when we saw it. We sent it for biopsy only. And then we sent the patient for hyperbaric oxygen therapy. When he came back after almost 20 dives, we could remove this necrotic bone without and the involved maxillary sinus linings, and reconstructed in the same sitting with buccal fat pad. And this was he after 1 month of reconstruction, and this was 1 month after the surgery, the debridement. Another patient, 30 years of age, non-diabetic, Non-smoker reported to us with a swelling of left side of face with deviated nasal septum, and there was also some inflammation and swelling in the buccal mucosa, in the posterior buccal mucosa. On CT scan, it showed involvement of the maxillary sinus, breach on the anterior wall of the maxilla, and involvement of the overlying soft tissue, infiltration into the overlying soft tissue. So he on biopsy, it came out to be aspergillosis. So he was started again with low dose amphotericin B, but he couldn't tolerate it, and his condition worsened over a period of 1 month. So we had to switch over to voriconazole, 200 milligram BD tablets for a period of almost 4 months. And this was he after 2 years of his surgery and antifungal treatment. Antifungal treatment was stopped after 4 months. In the coming to the patients in COVID era, this was a patient, 54 years male, who reported to us reported to us 6 months back with mucormycosis. But he had a history of COVID-19 infection some 7 months back with history of diabetes and was under medication. There was also history of medical admission and use of steroids. There was orbital involvement and partial blindness, and he had undergone FES with orbital decompression and antifungals. And when he reported to us, he had deranged liver and kidney function. So this was not visible. This kind of picture was not presented when he reported to us. He reported to us with a very whitish kind of exposed necrotic bone, which was still firmly attached to the surrounding bone. We didn't start antifungals for him, and we sent him for hyperbaric oxygen therapy after getting the HRCT score, which was favorable at 7. So adjuvant HBO therapy was done. Here you can see the involvement of maxillary, ethmoid and frontal sinuses before FES, and the necrotic maxilla, necrotic part of the maxilla. And this was after FES, immediately after FES. This patient was treated by debridement, and that piece of maxilla just could be removed without any difficulty because it was completely free. You can see the nasal turbinates, they are all healthy. The mucosa is all healthy. The bone, this part of the bone was necrotic. You can see a black hole here. So I removed these surrounding bones, and also curated out, entered the maxillary sinus and curated out the sinus lining. And superior reconstruction was done using superiorly based nasolabial flap in the same sitting, as the patient already had the disease for 7 months, and now he was almost disease free as seen clinically. And here, this is the intraoperative picture, the nasolabial flap in position, covering the defect, and this is he on extraoral appearance. This was done some 10 days back. Another case, 39 years of age with multiple gingival abscesses and mobile teeth, reported to us with COVID, history of COVID-19 infection 2 months back with high sugar level and is still under medication. History of steroid administration was there. But there was no history of medical admission or oxygen or treatment with oxygen. Multiple mobile teeth were detected with multiple draining sinuses. FES was done some 1 month back, and the patient is on antifungal medication. Partial inferior maxillectomy was done till bleeding, till we encountered bleeding surfaces and margins. Local application of methylene blue was done, and primary closure was done. The palatal palate was supported with a interim surgical obturator or a splint. Another similar patient, but this patient did not have any history of COVID infection, but had a history of fever some 1 month back. He was diabetic and was under medication. There was viral pneumonitis and the HRCT score was 14. There was no history of taking steroids. There were multiple mobile teeth, and there was more involvement of the maxillary sinus, and the maxilla was necrotic on the left side. So the involved teeth were extracted, and inferior maxillectomy of that portion was done, and the sinus was curated out, and all the sinus mucosa was visible sinus mucosa, diseased sinus mucosa was removed and primarily closed. Another patient, 34-year-old female patient, reported to us, but she also didn't have any history of COVID or any history of fever or anything. But on testing her serum antibodies, it came out to be positive with high antibody values, which were more than 300. The sugar level increased after sugar level increased during this first month after she got all these symptoms, and she is under medication for controlling the sugar level. The whole of the maxilla was mobile. There were multiple mobile teeth, buccal and palatal sinuses were present, and so complete inferior maxillectomy was done, except for the frontal processes of the maxilla. And the sinus, on CT scan, only one sinus seemed to be involved, but on surgical exploration, both the sinuses were involved. So the sinus linings and contents of the sinus were removed, and this was the stage after removal of all the necrotic bone. Methylene blue was applied and primary closure was done with support with a splint, which was suspended, which was fixed with circumzygomatic suspension wires to support the maxilla. This was a patient who reported to us 1 month back. There was 15 days back, and he had a history of COVID 1.5 months back and reported with multiple gingival abscesses in the mandible, in the left side of mandible. And on CBCT, there were erosions of the bone and the teeth were mobile. He only had the history of a single carious exposed molar and no other symptoms before suffering from COVID. There was paresthesia of the along the inferior alveolar nerve distribution and bony erosion. You can see the bony erosion on the CBCT. So a marginal resection of the mandible was done and all the teeth were removed. The dead and necrotic tissue were curated out. Methylene blue applied and primary closure was done, and we are still awaiting the biopsy reports. We haven't started any antifungal treatment, only started antibacterial treatment according to our departmental protocol for his prevention of post-surgical infection. That we do for all the patients in whom we do surgery. We always start post-surgical antibiotics, anti-inflammatory and serratiopeptidase to reduce the swelling. We don't give patients any steroids. These are the pictures of palatal support splint and obturators, interim obturators we use when we come across maxillary perforations. The drawbacks which we face are that we lack a team approach. There is scarcity of antifungals, mostly amphotericin B injection, unavailability of general anesthesia because we are dependent on our anesthesia services on Loknaik Hospital, which has been declared as a complete COVID hospital. So we are not getting anesthesia services right now, and we are managing our cases under local anesthesia. I would recommend control of blood sugar within normal limits, which is of paramount importance in preventing mucormycosis. Medication should be used in consultation with the treating physician. Self-medication is a total no-no and should be avoided at any cost. Adequate hydration has to be maintained to reduce drug-related toxicity. Injudicious use of antibiotics and antifungals are to be avoided. In patients with prior history of fever, sore throat, or any other symptoms of COVID-19, serum antibody for SARS-CoV-2 infection should be advised. Early diagnosis and aggressive surgical debridement is the first line of treatment. It should be the first line of treatment. Surgical debridement can be done under local anesthesia or general anesthesia, depending on extent of tissue involvement and patient's clinical status. Like if the patient has orbital involvement or cranial involvement, or it requires a complete maxillectomy, then we might have to go for a approach that includes intraoral as well as subciliary, or a Weber perfusion approach. Whenever in doubt, a frozen section has to be advised to see if the margins are free of disease intraoperatively. Antifungal therapy should be an adjunct to reduce the spread, mortality, and prevent end organ damage, and should not be a first line treatment modality. In suspicion of residual disease and to limit the progression of disease, and also in patients with um, chronic kidney diseases or patient toxic to antifungal drugs, hyperbaric oxygen therapy may be considered, keeping in select group of patients, keeping in mind the conditions where they cannot be advised. Reconstruction and rehabilitation have to be delayed till the patient is disease free. And I would always recommend a patient who has suffered from COVID-19 infection, even if there is the slightest of symptom like slight pain in tooth or mobility, or there is nasal stuffiness, or there is swelling or headache, to seek immediate consultation, because early intervention is the key to good prognosis of mucormycosis, or else the results will be very devastating. The patient might end up in having such kind of a picture, and even if we go for surgery, we remove all the tissues, necrotic tissues, the prognosis becomes very much guarded, and even if the patient survives, it becomes a great challenge for the quality of life. And these slides, or these patients are, this patient is not mine. These slides are shared to me by Dr. Virender Singh, who's a fellow maxillofacial surgeon and a good friend. He is the head of oral and maxillofacial surgery, PGI Rohtak. With this, I would like to conclude my talk. And at last, I would like to thank everyone in my department for their cooperation, my PGs, my faculty, my senior residents, students and staff, and a special thanks to Dr. Mithilesh, who has helped me in preparation of my talk, because I am not very computer savvy. So I have taken a lot of help from him in preparation of this. So, and thank you, Dr. Mandana and your team and the participants for your patient listening.
Dr. Selvi, yes, you can please take it.
Thank you, Dr. Aditya and Dr. Sujata. That was a very informative session. And especially you have described the differences in pre-COVID and post-COVID mucormycosis cases. And all your cases have been very excellently documented and presented. So going to the queries, there is one question for Dr. Sujata. What is postconazole level or index, and how useful is it for the treatment?
See, we are mostly using posaconazole tablets because we are not getting sufficient doses of amphotericin B injection. So posaconazole is also very much helpful, and the level is greater than 7 milligrams per milliliter for prophylaxis. And to reach that level, it needs to be started around 7 to 10 days prior to switching off from amphotericin B to posaconazole. And we do not start antifungal treatment unless and until we get a confirmatory diagnosis of mucormycosis. We do not start antifungal therapy at all.
So, are you saying that all these cases, the diagnosis is done only on the excisional biopsy?
Incisional biopsy also, if the patient comes for on incisional biopsy, first diagnosis is made. If the patient, mostly we get the patients who come to us after phase. So it is already diagnosed mucormycosis case and the patient is on antifungals. If the patient reports to us initially without getting the phase done, then we first go for an incisional biopsy, start the antifungal treatment along with debridement.
Okay, thank you, Doctor. Dr. Aditya, are you using potassium hydroxide mount and is it of any use in the initial diagnosis?
Yeah, potassium hydroxide is useful in the initial diagnosis, but the site from where the sample is taken is very important. So usually we get a nasal swab. So we can use a nasal swab specimen and then spread it onto the slide and do it. But if you're going to take it from the oral cavity, then it will not help much because unless there is a orointral fistula or something like that from where you can actually get the specimen properly, otherwise it will not come positive.
So in case there are initial stages, like some of the cases what was shown in post-COVID era. So in those cases, would it be, would a KOH mount help? Because especially there was just a mobile tooth or just a small swelling. Are you going to get
No, in those cases, the incisional biopsy will be needed because either the patient has a COVID history, and then your high index of suspicion is based on all the mobile teeth or the ulceration which you're seeing in the oral cavity. Then we would probably do an incisional biopsy first, confirm the diagnosis, and only then the excision would be done. In our case, what is happening is many of the cases are admitted in the ENT department in the medical hospital because our medical hospital is a purely COVID hospital. So the ENT department is then referring the cases to us for the maxillectomy or whatever surgical procedure which has to be done over here. So they're already having a diagnosis of mucormycosis with them.
Okay, thank you, Dr. Aditya. There is one query. You had talked about aspergillosis along with mucormycosis. Have you ever come across or have you looked for invasive candidiasis with mucormycosis in your histopathology slides?
We have seen candidal hyphae in association with the mucormycosis cases, but I have not seen clinically any case where it is only invasive candidiasis. We have not come across any cases.
I meant in post-COVID area, post-COVID.
No, in post-COVID, till now we have not got candidal infection associated with mucor.
Or that means you are screening for the candida and you're not getting it.
Yes, yes.
Because pre-COVID era, we have got cases where there were combination of aspergillosis and mucormycosis as mucormycosis and invasive candidiasis, especially when it occurs in the maxillary sinus. So my query was that for that. Thank you, Aditya. Dr. Kotreshetty, would you like to ask questions?
I would like to make a couple of observations. Because here at KLE is a tertiary hospital specialty, and I'm working in association with around 7 ENT surgeons. So what we do is, as soon as the patient comes, generally I see two trends in this mucormycosis. One is kind of an ascending infection, which tends to start from the terminates, goes up to the ethmoid, sphenoids, and to the orbit and up cranially. The second ones are they tend to get restricted to the orbital floor, maxillary sinus. So generally the ones which come to the orbital floor or the maxillary sinus are the one which we come across a little delayed. In the sense, in these cases, mostly the maxilla is completely necrosed, and that is when it gets infected and the patients come to us with mobile teeth, and we go in for a standard sublabial or cervical clavicular incision. We just extract the teeth and do a partial maxillectomy. These are the cases which come to us. In these cases, by and large, the mucormycosis is already restricted. So the job here is basically resection and reconstruction. But the other part, wherein when they report primarily with an ascending form of infection, we always go in for the standard. Of course, we go in for a KOH mount and culture as well as a biopsy. Within 3 days, we get the report. And in our hospital, it is a standard that, as soon as the diagnosis is done, luckily here, we are getting the deoxycholate, the amphotericin easily available. So we start with the amphotericin immediately, and then we go in for a nasal endoscopic surgery. And depending upon the nasal endoscopic surgery, further resection or the further debridement, whether there is a role of maxillofacial surgeon, is generally taken off, and then I come into the picture. But primarily, almost all these patients, they tend to go to ENT surgeon and they come to us. But nowadays, again, what I see is the ENT surgeons, they have treated the patients. Probably many of them, they miss to treat the maxillary part of it.
Yes.
They go and treat the nasal part and the ethmoidal and the sphenoidal part. These patients are now coming back to the dental clinic with mobility of the teeth. So in those cases, probably I don't think so there is any role of doing KOH mount or or any studies. It is straightforward excision, extractions of the mobile teeth, removal of all the chalky white bone till you get the sensate bleeding bone, and then do whatever form is necessary for to obturate that area and try to go in for a reconstruction. Dr. Sujata can comment further on this.
Actually, we also get similar kind of cases where they have already undergone phase in ENT department and they report to us after that. When there is already maxillary involvement with mobile teeth, and also the sinus are still filled with diseased necrotic tissue. In such cases, and we do not have general anesthesia right now, so we do all these cases under local anesthesia, and we don't go for primary reconstruction because we are not sure whether the disease, the patient is free of disease or not. And it's only 1 month since we are seeing such kind of cases, and the patients are still on antifungals and they are on investigation. So we have to wait another 3 to 6 months maybe to comment on the progression of the disease and to go for secondary reconstruction or rehabilitation.
The other point which I see in this post-COVID mucormycosis is that the pre-COVID disease used to be a very long and progressive one.
It was a chronic course. It used to run a chronic course.
So we used to follow up the patient for nearly 6 to 7 months and then pronounce them as disease-free. But somehow during this post-COVID era, the patients, they tend to, deteriorate very fast.
Yes.
So I've seen patients within 20-25 days deteriorating, and they land up into cerebral complications and they just die. So the intensity of the disease following the Delta variant of COVID has been more devastating to the dentofacial tissues than compared to the the pre-COVID era. So these are some observations which I see. And also what I see sometimes is that when these patients come, like there are a lot of dental surgeons who ask me, what do you do? How do you diagnose? So many of them, they get confused with the existing periapical diseases and the COVID, the abscesses, multiple abscesses which come in over there. So I tell them, this is my observation, is that most of the times I see that it is the canine and the premolar teeth which tend to become mobile first before the other teeth.
And
before the other teeth tend to become mobile. So general guideline I give them is that, look for mobility of these teeth. And if you find there is a mobility of these teeth without association to the existing periapical pathology, then take a ENT help well in advance, establish a diagnosis, and then start treating. This is general advice I give it to all the patients.
Thank you.
I have one little query there in conjunction with that. Considering that this is so aggressive now, in the post-COVID time, it is so aggressive. When you weigh the, the pros and cons of when a patient is coming, say, with very, very highly suspicious symptoms, then what is the how much is the risk of starting your antifungal immediately rather than waiting for those 2 to 3 days of confirming the diagnosis. If you just weigh, I mean, I know obviously antifungals have their own drawbacks, but if you weigh the two things against each other,
You
what
want
you
me
all
to
have
answer
to
that, Mandy?
yeah,
Should I
any
answer?
of you
Yeah.
can answer, please. Yeah.
When I talk to the infection control specialist, I mean, at our hospital, mucormycosis is definitely both a surgical as well as a medical emergency. We have to consider that. In case when you get, even if the patient is COVID positive, all right, so you come across a mucormycosis, it is important that we immediately don on our PPEs and we go in and do the debridement, whether it is a ENT surgeon or whether maxillofacial surgeon is needed. And then the medical specialist will immediately assess the patient's immunological status, try to control the blood sugars, and the amphotericin has to be started immediately. There are a lot of problems which was mentioned by Dr. Sujata. One is the primary transfusion related storm, followed by the secondary nephrotoxicity and etc. etc. So it is mandatory that you, in a team, you must have an infection control specialist, and you may require even the help of dialysis as well. So it is surgical and medical emergency. So both the things will have to start at the same time.
So essentially, you do the debridement right away. You don't necessarily wait for a diagnosis to come.
No, because during this time after the post-COVID era, now I think the most of the surgeons are quite well accustomed to understand what mucormycosis, and we can pick it up rather early. The patient comes with a necrotic tissue, we go ahead and we debride it. The reports can wait because the reports are going to take 2 or 3 days to come in, but it is essential that we remove all the necrotic tissue and allow the amphotericin B to come into that area and start working against the fungals. But if you just don't do the debridement, it's not really going to be any use.
Right. So that's a very important thing. So I think that one of the main things is getting the patient to the right people as soon as possible.
Yes.
So that immediate treatment can start.
Yes. It is always the team management, which was very well covered by Dr. Mohante. I think her words are absolutely true, that it is always a team management. It is not that one person can sort this out.
But I think mainly that if in today's situation, if any of our dental colleagues outside of a hospital setting see a suspected case, they should not wait for a diagnosis. They should refer the case almost immediately and let everything happen in the hospital itself.
Yeah, I would put it in 2 ways, Bandhana, that, in a tier 1, tier 2 cities, probably, yes, I understand that I can refer to a higher center immediately. But West, as you start going more interior, I would suggest that, the many of these patients are unable to even travel also because of many restrictions as well as financial condition, everything. So if a dental surgeon comes across a mobile teeth, yeah, I think he should raise a flap, extract those teeth and try to debride the bone as much as possible before the patient can arrange and come out to a tertiary center for further treatment. So, we cannot be very judgmental saying that this is going to be the treatment, because the panels are created where we are sitting in a more, what should I say, a tertiary center where all the facilities are easily available to us, so we can talk about protocols. But as we go down to more smaller cities, it's probably not possible to follow all these protocols, what are laid down. So treatment has to start immediately. So I think extraction and debridement should be done as soon as possible.
First line.
Thank you. All right, I will let you all go back to.
Oh yeah.
Dr. Aditya, one of the queries is, do we need to comment on margins in resection specimens of mucormycosis?
Can you repeat the question, ma'am?
Do we need to comment on the margins in resection specimens of mucormycosis?
Yeah, we can take the sections and we can ensure that whether margins are free or not, because then you're 100% sure that the surgeon has removed the entire tissue completely. So it is good for the prognosis of the patient. So we should ideally be doing it. Even otherwise also, as ma'am has also mentioned, sometimes frozen sections are also needed to, during surgery, so that if they're not getting good healthy bone, and if the frozen sections are evaluated, then it will lead to a better prognosis for the patient.
So that was the next query from Dr. Jose Hille. Why don't you use frozen section for rapid confirmation of mucormycosis?
The question is directed to me?
Yeah. Why don't you use frozen?
No, we have not got into doing frozen sections for rapid diagnosis, probably because we're only using KOH. And as I told you, the cases are coming from the medical hospital later on to us for treatment. So we have not got into that of doing frozen sections actually.
Can I come in here to just make one comment? We as surgeons, we are also seeing in two types of presentations. When the patients come rather early and when we're trying to debride them without the systemic antifungals kicking in, the margins are not very clear in most of the situation. So I don't know how pathologists look at it. We surgeons, when we're resecting, we try to look clinically as to whether the bleeding bone is present and clinically whether does it look healthy. So those are the two parameters we look for. We haven't sent any case for rapid frozen section when we are trying to do the clearance. The second cases we get is when the patients are already on amphotericin. We see that there is a clear-cut demarcation between the normal bone and the sequestered bone when we do contrast enhanced CT scan. So in those situations, for us surgeons, it becomes rather easier to go and resect the dead part, clearly. But in cases wherein early cases when they come in, it is little difficult for us surgeons to exactly determine. And second other point is what I should say here is mucormycosis is not that once we resect it's going to end there. It is not so. Many of these patients, the further spread of infection is seen and we may have to go in and debride it again and again. So there is a weekly or twice a weekly debridement which is done by using the nasal endoscopy by the ENT surgeons. These episodes can go to a period of about 4 to 5 months till both radiologically as well as clinically and histologically it is proven that the patient is disease free.
Thank you, doctor. I think that's the end of the question raised in YouTube. Dr. Raghu, would you like to add some queries or comments?
Thank you so much, Selvi. I mean, I thoroughly enjoyed both the presentations, and particularly because I am a pathologist, I think I could connect or rather relate better with Adita's presentation. And I mean, the differences that she saw in her cases, the ones which were associated with COVID and the ones which were not associated with COVID, I think was a standout observation for me. Particularly, she also mentioned about the role of netosis. And I was actually thinking why exactly there is an increase in the necrosis in patients with mucormycosis post-COVID than those which are seen in patients before COVID. So I was actually trying to bring in a link between the netosis and the necrosis itself, because the netosis itself resembles necrosis in that both the membranes are not intact and they leak out those intracellular proteins outside of the cell. And that perhaps is the reason that you see more of necrosis, because SARS-CoV-2 is known to stimulate these extracellular neutrophilic traps, a process called the netosis. So I was thinking that the netosis is perhaps the reason why there are increased necrosis seen in patients with mucormycosis post-COVID. I mean, I don't know if Adita wants to add anything more.
No, that's what I said. Actually, the netosis has been explained only for the COVID-19. So probably we need to research on this area to see the association between the netosis and the mucormycosis. So probably research in this area would prove that there is a connection, because the thrombosis has a major role to play in it.
Correct. Yeah. Thank you very much. Both the presentations were great.
I think with this, in the post-COVID time, we are going to have a little change of the way this whole disease presents for some time at least. Because, if fungi could go down on their knees and pray for something that would make them more powerful, I think their prayer would have been COVID-19. Because it has managed to hit at so many levels, whether it is with our treatment or whether it is with the fact that it interferes with by causing thrombosis, which itself again causes death of bone, whether it is by increasing the its diabetogenic factor, where we have seen absurd sugar levels of 600. It's just one of those things that really is hitting at so many levels. And now I mean, with everyone here, I just have to say, what do you feel in the, okay, we passed the wave, we are passing the second wave. In the second wave, we had a lot of cases that were still in the hospital when they got infected. Now, complication, post complication. How do you have any feeling of what it's going to be in terms of looking for and the COVID that might be coming, we might be coming across in the next few months? Yes, who wants to go first?
Dr. Sujata?
Yeah, good try. You can go first.
Dr. Sujata would like to comment, then I'll speak afterwards.
Yeah, okay.
You can continue, sir.
Yeah. I personally, I mean, it's a general trends. What I see is that now the second wave is coming down, but I definitely foresee the third wave coming because ICMR has got the mathematical models which support this, saying that the third wave is likely to be there. And also the ICMR has already issues guidelines for children between 6 years to 12 years or 18 years. I'm not sure. There are different guidelines for children as to how to protect them from COVID, and also trials are being carried on children between the age group of 2 to 12, if I'm right. So I think the government knows it that the third wave is expected. And also, I just see that yesterday the lockdown in our city got over, and I see still people coming out like as if it's a festival without any mask. So end of the day, I still come to the same point saying that, please wear a, a 3-layer cloth mask or a surgical mask. Keep the social distance, wash your hands. If you don't get COVID, if you can save yourself from COVID, you can save from all other complications. So till such time that the science progresses to understand the implications as well as the ramifications of COVID, and they come out with the thorough treatment modalities, right now, vaccination and these basic modalities are the ones which can save us from COVID.
Dr. Sujata, please.
Yeah, these are also my thoughts. And Delhi has also lifted the lockdown 1 week back. And same here, people are moving around without masks and mingling with each other. There is a lot of crowd in the markets, in the vegetable markets. So as if the COVID wave has ended. So these factors will definitely lead to a third wave. So to prevent that, we have to motivate people to go for vaccination, because most of our people, mostly the lower socio-economic class, they do not want to go for vaccination. We have to push them for vaccination and maintain COVID appropriate behavior to prevent a third wave coming in. And that way we can also decrease the chances of COVID infection and the complications related to it.
Very true. Dr. Aditya?
Yeah, I guess that about sums it up from both of them. And it's the same thing that basically we have to follow the protocol. And like today, I read an article that I think there are 25 cases of the Delta Plus variant which has been reported, and that is said to be more contagious than the Delta variant. So if that is going to happen, then we're going to be in for a bad time again.
Yeah. Hopefully, we'll be more prepared.
Yeah.
Yes.
But they are saying the third wave is not going to be that devastating like that of the second wave. Most of the people would have been vaccinated by then, and Dr. Guleria was live on TV on that day, and he was saying it might take around 6 to 8 weeks from now on for the third wave to hit India, and it might not be that severe as compared to the second wave. And that too, if people follow the COVID appropriate behavior.
We do keep our fingers crossed, Dr. Mohante.
Fingers crossed.
Fingers crossed. That's what I would say.
Yes, more, definitely.
Actually, I feel
it takes a long time because we need to get people vaccinated, and our numbers are rather daunting. So it takes us time.
Also I would like to add, I feel that genome sequencing of all the samples which are coming positive should be done on a regular basis to identify if any mutations are happening, and which I feel was not done last time, and that is how the Delta variant never got identified in the early phases when it was spreading in India. So if we are seeing further mutations now, So the genome sequencing should be done on a priority basis so that we can identify the newer variants and then take precautionary measures against it.
There is a last query. What is the fate of mucormycosis and fungal infection in third wave?
I think we just spoke about it.
For that, we have to wait and watch for the third wave to hit us.
I would think that, I hope the second wave, the mucormycosis has largely affected the young and the old population,
Yes.
I should say. And I hope that, the third wave, which is predicted in children, should not cause the same amount of devastation on the dentofacial structures. That is what we hope for. And I think it is necessary that, there are guidelines which are again being issued even in our hospital for the third wave, for the pediatricians and all to be prepared with the PICU and additional care, whatever is necessary. And of course, remdesivir cannot be used in children. That is another one more problem. So I think it is necessary that to be prepared, I think we'll win half the war. Yeah.
I think we need to, by then, possibly, like you were mentioning very rightly about the more peripheral, the rural areas
Yes,
and the cities.
yes.
I think each area needs to now, maybe from the dental profession itself, also we need to have a guideline of what to do if we have any of these suspected things and how to go about it. So we are more prepared and a little, we can act faster and more appropriately. Yeah. Raghu, did you have to say anything?
No, I think pretty much everybody has summed it up, and I echo Dr. Kuttashetty's and Dr. Sujata's views. I mean, I think the only way forward is the non-pharmacological intervention. And this is something I think in the very first wave, when there was a study that was carried out in the Cambridge Institute, they did show with evidence that the only way you can prevent the spread or you can stop the spread of COVID is non-pharmacological interventions. But then I don't know, I think Guleria also alluded to the point that in India, it is very difficult for people to be better behaved. And as he was saying that, once you lift the lockdown, it's again a festival time for us.
Yeah.
So I think unless we inculcate some discipline in us, we will see third wave, fourth wave, and newer variants. It's unfortunate.
Dr. Sujata, just wanted one query, for a lot of cases, have you been using the hyperbaric oxygen?
No, not lot many cases. We have used it only in 2 cases. One that we operated and one he has gone for hyperbaric oxygen therapy. It is still undergoing. And we have not seen many, we didn't see many mucormycosis cases till 1 month back. And for the past 1 month, we are seeing mucormycosis cases, like every day we are seeing around 3 to 5 mucormycosis cases, mostly referred from ENT and mostly with maxilla involvement, as you have already said. And I only suggest this hyperbaric oxygen to patients after confirming from HRCT that the lungs is free of infection. And also where the bone is still attached to the, it is not separated from the surrounding bone, the patient is not on antifungals, and if there is renal toxicity where antifungals are contraindicated, only in such patients after proper assessment, then only we are sending the patients for hyperbaric oxygen therapy, otherwise not.
So you feel probably either it should be very early or later?
Yeah, it should be very early or later when it becomes chronic. Like the other patient which we had, he had developed renal and hepatotoxicity, and he had already had orbital extension, or he had undergone orbital decompression. So in order to decrease the spread of the disease, as I have already said, because of the mechanism of action of hyperbaric oxygen therapy, that's why I have advised. So there is no data to support the use of hyperbaric oxygen therapy till now on COVID related mucormycosis. So,
I think the second one is the difficulty with availability of hyperbaric oxygen.
Yeah,
is also
exactly,
one of the issues
because
for us.
it was available in one government setup in Delhi, RML hospital, but because it is a COVID hospital, it has been declared as a COVID hospital, that facility is also closed. So the second patient is getting it done from Apollo, I think Apollo or Gangaram Hospital,
Okay.
where there is a hyperbaric oxygen facility. That
And
depends on the availability of the
Madam, are you aware of community surgeons also sending patients for hyperbaric oxygen therapy?
No, I am not aware of that. I don't think they are sending for hyperbaric oxygen therapy.
Okay. And are they using the antiplatelet drugs also in these patients?
No, I don't think they are helping. Antiplatelet drugs usually
Exactly.
help because already there is thrombus formation,
Yes,
and
exactly.
antiplatelet drugs, after the formation of thrombus, there is no role of antiplatelet drugs. Even if the patients are using, they are using antiplatelet drugs during the COVID treatment, still the patients are coming up with
With
mucormycosis. Still they are
requirement.
reporting with mucormycosis.
Agreed. Agreed. Thank you. Thank you very much.
Interesting. Right. So thank you very much. That was a lovely presentation by Dr. Sujata and Dr. Aditya.
Thank you, Dr. Mazan.
You know, when I asked them, I requested them and I said, we want to see if we are getting any difference between the pre-COVID and the COVID. They were a little like, but they really put in a hard work, I think, ever since then. And I've
I think,
probably studied
it's in
every
many
case
ways
in
eye-opening.
detail.
No, we are literally catching out of every patient who's coming in. You know?
and it was because till the last 1 month we were not getting to see many of these post-COVID mucormycosis cases. That's why when Aditya asked me, "Are you going to talk on post-COVID mucormycosis?" Then I said, "Just wait for some time. Let us come across some mucormycosis cases." And now it is like a flood of mucormycosis cases. Every day our department is getting 4-5 mucormycosis cases. So we have not yet crossed the 100 mark, but we are very close to the 100 mark.
In fact, ma'am has sent so many cases that I'm confused when I'm seeing slides as to know which patient am I seeing when I have to give a diagnosis, because every case is a case of
And the
mucormycosis.
mucormycosis of COVID and mucormycosis of pre-COVID mucormycosis was like dry, and it was found to be attached to the adjacent bone. And this kind of mucormycosis is just when you try to remove it, just falls off in your hand. It is separated from the bone by a lot of granulation tissue. And there is a lot of avascular necrosis surrounding it.
In 5-6 months, we will have another round, and then you can really discuss these
And
multiples
for
of
the
case
prognosis,
series.
we have to wait for another 3 to 6 months to
Yes.
see what exactly happens to the patient whom we treated, even during the initial phases.
Yes.
So as
Very true.
Dr. Kotra Shetty also has pointed out, it needs frequent phase to see the progress of the disease, whether the patient is cured of disease or whether there is residual disease or it is recurred. So, and maybe multiple debridements.
So that was a wonderful session, and I think we will just wrap it up with one little word of warning from the Professor Hele, who is from Africa, who has said, please be wary of the third wave. The curves are much steeper. So with that little warning, and also the fact, I think we need to mention to everybody watching that every one of us is in a room all by ourselves. As you can see there, you can even
That's
see
why
one
we are
closed
not
door there.
wearing masks.
Which is why we are without masks. Yes, saying Raghu is already getting ready. So yeah, so it's like decided first thing that everybody closed doors and they were on their own. So please don't think we are otherwise without masks. We are all wearing masks and double masks nowadays. Yes. So with that, I am going to just share the screen and give me a minute, please.
Thank you, Dr. Sujata, and thank you, Dr. Aditya.
Thank you. Thanks a lot.
Yeah, thank you so much.
Thanks for having us.
Excellent presentations with well-documented and very good histopathological pictures. Yes, Mandana, please.
Yes, no worries. It's okay. Wonderful. Yes. Thank you, Aditya. That was wonderful presentation. Thank you so
Welcome.
much. And Dr. Sujata, excellent presentation. Thank you for the time you took to put all those cases together. I know it must be busy within all your other work and the clinical work you have to do.
My pleasure. That way I did many cases, and luckily we came across a lot of cases just before the presentation.
It was meant to be. It's fate. Okay. So, yes, thank you.
Okay. Thank you to
And-
everyone. It was a very invigorating session, and I think we all learned a lot from the interactions that we have
Yes.
had. Thank you so much.
Thank you.
So, Selvi, you can add this to your collection of certificates.
Thank you, Dr. Mandana, for inviting me here.
Oh, it's always a pleasure to have you here. And yes, Kutrashati, thank you
Hi,
so
Mandy.
much.
Thank you so much.
Yes, thank you for being here. It was particularly fun and great to have you on this show, of course, because, well, like I said, we go back 30 odd years, so it's
Yeah.
always good.
Thank you, Mandy. I think it was a
Thank
very
you,
interesting
Dr.
session discussing with all the experts on the panel. Lovely. Thank you so much.
Yeah, thanks meeting you, Dr. Kota Shetty. I had never met you.
Thank you, Dr. Sujata. It was really lovely listening to your lecture as well as the discussions. Hope so in one of the near future conferences, we'll definitely get in touch again.
Yeah, sure.
Thank you.
Part of the purpose of this whole channel is to get everyone to interact and meet. So that is fulfilled. Yes. Thank you, guests. And Raghu dear, thank you so much for being here. I will send you your certificate later.
Thank you.
Yes.
Anytime. Thank
Actually,
you so
we
much,
shouldn't have
Vandana.
to
Thank
give
you
you
so
a...
much, Aditya. I've always enjoyed listening to your presentation. I can any day listen to your talks.
Yeah, thank you so much, Dr. Raghu. Thank you so much.
Yes. And Raghu is essentially a part of the team. I don't think I need to even give him a certificate.
So he takes out so much of time to attend all the webinars, so that's really commendable, actually.
Yes, exactly. He's sort of an honorary member of Team Oral Pathology India. Yes, now some little bit of information for the forthcoming events. Yes. We were supposed to have Dr. TV Narayan sometime back, and then that was delayed, but he's coming back and he's coming next week. And of course, being both an oral pathologist and an implantologist, he has a very interesting presentation. It is about implant-related pathology. So this is open again to all our colleagues. This is on the dentistry special. So all dentists with an interest in implants, well, please join us. It will be lovely to have you. And also please share it. Then there is, of course, this I have just shared yesterday also with a lot of colleagues. This is membership is available to the Asian Society of Oral and Maxillofacial Pathology. Now, if you just go to the website and click the membership, if anyone requires, there's a proposer required. If you need a proposer name and email, please get in touch with me. And please note that email which is given on that is not the same email I have registered at the site. So please get in touch with me. I'll give you the right email. This will be very good because it is for all clinicians with an interest in oral pathology or head and neck pathology. Yes, and with that, we are all set to end the session. Thank you again. Thank you, everyone. It was lovely having you here.
Thank you so much.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.
Bye. Bye.